Está a cargo el doctor Berthold Kolesko. El doctor Kolesko es profesor titular de pediatría en la Ludwig Maximilians Universidad de Múnich. Se formó en pediatría en el Hospital Baranguanat de Johannesburgo, en el Centro Médico Cristiano Kilimanjaro, Mochi, Tanzania. Además, en los hospitales infantiles de las universidades de Düsseldorf y Toronto. Su trabajo se centra en los moduladores metabólicos y nutricionales de la salud infantil y en la prevención de enfermedades. Con más de 1.100 artículos de revistas científicas escritos, el profesor Kolesko se desempeña como editor en jefe de los Anales de Nutrición y Metabolismo. También es expresidente de la Federación de la Sociedad Internacional de Gastroenterología, Hepatología y Nutrición Pediátrica, de la Sociedad Europea de Gastroenterología, Hepatología y Nutrición Pediátrica y la Sociedad Internacional para la Investigación en Leche Humana y Lactancia. Además, en la Sociedad Alemana de Gastroenterología, Hepatología y Nutrición Pediátrica y en la Sociedad de Medicina Nutricional. Es presidente de la Academia Europea de Pediatría. Su conferencia se titula Diagnóstico y tratamiento de la hipercolesterolemia en niños y adolescentes. Bienvenido, profesor Kolesko.
Muchas gracias. Good afternoon. At the end of a long morning, and you're probably looking forward to the break, I'm going to share with you some thoughts on diagnosis and treatment of hypercholesterolemia. But first, I would like to thank and congratulate the organizers of this meeting. It's been a fantastic experience. I'm really grateful for having had the opportunity to be here. And it's just amazing what spirit you have created. There's so many people. It was so fantastic interaction. I really enjoyed talking to so many of the colleagues. I'm also grateful that you put this topic on the program because I feel sometimes that in pediatrics we don't put too much attention to hypercholesterolemia and its detection and treatment. And I think we could do more in the interest of the children that we care for. I have no conflict of interest in relation to this topic. I have no financial relationship to any manufacturers of lipid-lowering drugs or diagnostic tools. So we all know heart disease and stroke are the world's biggest killers. More than 1 in 4 people around the world die from heart attack and stroke. But they die at an old age, 40, 50, 60 or older. And you can say, why should we worry about this in pediatrics? Why are we in pediatrics interested in preventing heart attacks? Well, the reality is that the beginning of heart disease is early in life. We are born with very clean arteries, but already in the first year of life, when we have a very fatty diet, there are fat depositions in the intima media of our arteries, and from about puberty onwards, fibrous lesions start to develop, which are permanent, which don't go back anymore. And then, depending on how rapidly and how strongly these lesions develop, then clinical consequences occur, coronary heart disease, stroke, or other vascular diseases. So it's clear that the risk of developing a heart attack and the question when it will develop depends very much on what's happening throughout the life course, beginning in childhood. We know a lot of risk factors for cardiovascular diseases. There are some that are not modifiable. Genetics, if you are a male, you have a higher risk, you can't change that. There is other things that we can modify in pediatrics that we get very excited about, this whole concept of early metabolic programming we have learned if children have a very rapid weight gain in infancy in the first 2 years of life, they have an increased risk of diabetes and heart disease later, particularly if they are born small, if they have a low birth weight or a preterm baby. And there's other modifiable risk in the total population that we know: obesity, certain dietary aspects, physical inactivity, smoking, hypertension that we often don't screen for enough in pediatrics. We don't measure blood pressure enough in pediatrics, I feel. And of course, lipid disorders, an elevation of the adverse low-density lipoprotein cholesterol, a low level of the protective high-density lipoprotein cholesterol, and hypertriglyceridemia, which is associated with low HDL, and of course diabetes. So here we have an opportunity to prevent. And it's clear the earlier we start, the bigger is the benefit. Nowadays, often people start to take lipid-lowering drugs at the age of 50, 60, or after the first heart attack, and that works. But if you look at the data, if you start to lower cholesterol at age 70, your risk reduction is about 20% for coronary heart disease. If you start at 40 years, the risk reduction is 1/2. And if you start in childhood, we don't have data, but we would assume we have an even better benefit. And this is what this consensus statement of the European Atherosclerosis Society concluded: early detection and treatment of hypercholesterolemia can literally save decades of life, That's a strong message. We are particularly interested in the severe forms of hypercholesterolemia because for these we know if we detect and treat them, and we achieve a real benefit. If you have a mild hypercholesterolemia in a child, we really don't know how much benefit we achieve and what the benefit to burden ratio, benefit-cost ratio would be. But for the severe forms of hypercholesterolemia, it's clear if we detect and treat, we have a benefit. And the most important form is the familial hypercholesterolemia that I will go into detail in a moment. But you see there's also a number of other forms that are having severe consequences for affected children. And then we have a number of secondary forms. And these are actually proportionally more common in children than in adults. And we all know them. Of course, overweight children have increased lipids, obese children have increased lipids, but mostly triglycerides. Anorexia, hypothyroidosis, diabetes, Cushing, and a number of other diseases, metabolic diseases, are associated with hyperlipidemia, liver disease, renal disease, and of course, substance intakes. And one thing that we should keep in mind in our adolescent patients is, of course, oral contraceptives have a role to play in increasing risk, and it depends very much on which oral contraceptives one chooses. So this is a child with a severe, or these are two children with a severe form of familial hypercholesterolemia, the so-called homozygous hypercholesterolemia. And you can see the disease if you just examine the child. The boy on the left at 7 years has these cholesterol deposits in the skin in the elbows. The boy on the right also has it on the elbows and on the knees. And you can imagine if you have so much cholesterol deposition in the skin, there's also enormous cholesterol deposition in the arteries. And in fact, the boy on the right, who we saw the first time at the age of 12 years, we sent directly to cardiac surgery because he had this severe stenosis of the coronary artery, and he had a severe damage of the aortic valve, and he needed aortic valve replacement and coronary surgery at the age of 12 years. So a very severe disease. If we don't diagnose and treat these children, they are most likely dead by the age of 20 years. So it's very important to find these severe forms. It's rare. 1 in 250,000 to 1.5 million newborn babies. In some regions, Lebanon, South Africa, Quebec, the frequency is higher. The cause of the disease is a genetic defect in the receptor that binds LDL cholesterol, and therefore LDL cholesterol cannot be taken up from the blood into the hepatocytes and other tissues where it is utilized, and therefore you have a very high serum cholesterol, usually 600 to 1,000 milligrams or 15 to 25 millimole per liter. And you can see there's a variety of different mutations behind this. Clinically, we see from school age onwards cholesterol deposits in the skin. We see cholesterol deposits in the cornea. And from about 10 years onwards, we have clinical manifest atherosclerotic disease. And as I said, untreated, we often have sudden deaths from acute heart disease. We had one family where one boy died at the age of 18 by playing football, and therefore we diagnosed his younger sibling with the disease. We can treat it well. In the past, we often did liver transplantation. That now is not necessary anymore because we have become much more good with less invasive treatments, drugs, and a kind of a dialysis to reduce LDL. Much more common and important for every pediatrician is the heterozygous form of the same disease. There you don't have both genes, but just one gene affected that enables complete function of the LDL receptor. That's found in Europe in 1 in 250 babies. In other words, every single pediatrician sees these children. Only many don't know they have these children in their patient, but 1 in 250 children you see has this disease. Because it's heterozygote, the LDL receptor function is reduced by about 1/2. And that leads again to the inability to normally extract LDL cholesterol from the blood and the tissue, and the LDL cholesterol is increased to typically more than 230 milligrams per deciliter or 6 millimole. And, that's the total cholesterol, and LDL above 160 and 4.9 millimole. These children don't have symptoms. If you examine them, you find nothing. Sometimes you have a family history where the father or the grandfather died early, but oftentimes it's not known what exactly was the cause, why the father died early. But if the parents are young, the family history is empty because they are too young to have a heart attack yet, even if they are affected. And if you ask yourself, do you know the cholesterol level of your grandparents? I guess 99% of you will not know. So if you ask the families, do you have hypercholesterolemia in your family? Most parents will have no idea what that was. So the family history is relevant if you see there was an early sudden death, or you know there's a myocardial infarction before the age of 60 in the family. But if you have no family history, then clinically you can't find it. But you can treat these children if you find them. So this is basically the summary. If you have no hypercholesterolemia, still you get cholesterol deposits, and if you get old enough, you have a certain likelihood to have cardiovascular disease. But if you have familial hypercholesterolemia, you have a high likelihood to develop coronary heart disease earlier in life, with homozygous FH before the age of 20, with heterozygous familial hypercholesterolemia. You find in systematic studies already at 18 years coronary artery changes, and by the age of 30 or more, you develop manifest coronary heart disease. How do we diagnose these? Well, we measure cholesterol and LDL cholesterol, and we consider elevated values, total cholesterol values above 200 milligrams per deciliter, and LDL cholesterol milligram above 130 milligrams per deciliter. So that is sort of the guideline when we become suspicious. And we have diagnostic criteria. There is a nice score from the Dutch Lipid Clinic network that allows you to say, is this likely to be familial hypercholesterolemia? So in children, you would say if the cholesterol is above 220, or in adults above 290, then we suspect it and would do further measurements. The good news is the total cholesterol you can measure at any time of the day. It doesn't have to be a fasted child. Any time of the day is informative. The total cholesterol doesn't change much. So if you take blood samples for another reason, you can just measure cholesterol with it. However, if the child is sick, if it has a high fever, it is catabolic, then the cholesterol level typically is 10% lower than in a healthy state. So keep that in mind. Again, if you have marked cholesterol in relatives first or second degrees, if you have xanthomas in patients or in relatives, if you have ischemic heart disease in the family before the age of 60 years, then you suspect there could be familial hypercholesterolemia, and you would then not only measure cholesterol, but you also would measure LDL cholesterol and HDL cholesterol, because that is really more informative. In children, oftentimes you have a high proportion of HDL cholesterol, and therefore measuring LDL cholesterol is important if the total cholesterol is elevated. We can now easily confirm this by DNA testing, but actually it doesn't really change the management. So if you don't have DNA testing available, it doesn't matter. If you just have the LDL cholesterol measurements, you have enough guidance to guide your treatment. The treatment depends on modification of diet and lifestyle, and if this alone is not enough, which is the case in FH, then we also need lipid-lowering drugs that we use from primary school age onwards. Another important aspect in risk assessment is measuring lipoprotein little a. It's basically the same as an LDL particle. You see the orange LDL particle, which is a drop of oil covered by these polar lipids that make the oil float in the watery blood. And it is linked to an apoprotein that is very closely linked to proteins that are regulating our blood clotting. And so lipoprotein A, if it's elevated above 30 milligrams per deciliter, is associated with a higher risk of thrombosis, even pediatric strokes, independent of hypercholesterolemia. So far, we don't have good treatment to lower the lipoprotein A, but we know if you have a high cholesterol and a high LPA, then you have a very high risk for developing heart disease, and therefore in these children, we would be much more clear in lowering the LDL cholesterol. But the good news is there's new treatments being developed, antisense oligonucleotides, small interfering RNAs, that in studies in adults are very effective in lowering LPA levels. So I expect this will become available for children as well in the very near future. So how do we find these cases? Well, one strategy I already told you, which is we ask for the family history, cardiovascular disease, known hypercholesterolemia, lipid deposits in the skin, and then in those where we have a positive family history, we measure cholesterol. The second option is to do so-called cascade screening, where you start systematically to test all the relatives that are near an index case, going up the generations, going down. So going from the child to the parents, from the parents to the child. And each time you identify a new patient, you continue the cascade screening to the next group of relatives around them. And the third option that is discussed is population-wide screening. In other words, in every child, at one point, measure one time total cholesterol. There is very controversial views on screening everybody. The National Institute of Clinical Excellence in the United Kingdom has done a systematic data review, and they have not supported population-wide screening. Last year, the Preventive Services Task Force in the United States has done a systematic review, very good methodological approach, I must say, and they have not made a recommendation for or against. They have said we cannot take a decision. The data is not strong enough to decide. the current evidence does not suffice to draw firm conclusions on what are the benefits and what are the untoward effects. If you ask, are the benefits reduction of heart disease decades later? There's simply no evidence for that. However, other societies have made weak recommendations in favor of population screening. Canadian Cardiovascular Society, American College of Cardiology, American Heart Association, and they have taken into account not only randomized clinical trials as the Preventive Services Task Force, but they've also looked at evidence from observational and cohort studies, and then they came to a different conclusion. So it's a difficult situation where we probably can justify either choice, measure cholesterol in everybody or don't do it. Well, if we want to treat children, the first thing is to modify lifestyle. And this, we all know, is very effective risk increase. This kind of lifestyle with high energy intake, high intake of saturated fatty acids, along with smoking, high sugar intake, that's a very good strategy to get a heart attack. We all know that, right? So this is something that is difficult to teach to families, but if they are motivated, if they understand, we can be successful. So we do dietary modification from about 2 to 3 years onwards. Before it's very complicated, but from about 2 years we can do it. Obviously, we want normal weight and growth. We don't want to restrict calories too much. The emphasis is on replacing saturated fats and hardened fats, trans fatty acids, by unsaturated fatty acids. Less animal fats, less coconut fat, more unsaturated oils, whether it's canola oil or soybean oil or whatever you have, sunflower oil, all of these fats lower cholesterol. And this is more effective than restricting cholesterol intake. So the quality of dietary fatty acids is the key factor in lowering cholesterol. And that means we need to reduce also the foods that are rich in saturated fatty acids. For example, red meat, we would rather replace with fish or poultry, or reduce the overall intake of meat and have more vegetables. More dietary fiber is very helpful. Nuts are very helpful, but of course not the salted, but the unsalted nuts. And this is effective. A Cochrane review said reducing saturated fatty acid intake reduced cardiovascular event risk by 14%. That's quite a large number on a population basis. And it's the fat modification, not fat reduction again. The important thing is not to eat low fat, but to eat the right fats, reduce saturated and replace them by unsaturated. That's the key to reduce the cholesterol and LDL cholesterol. Does it work in children? Yes, it does. This is data from some of our children, 34 children, followed over 18 months. And you see just dietary modification alone lowers cholesterol and LDL cholesterol significantly. It works in real life. You just need to have good counseling of the families. You need a dietitian that can help the family to understand how do we do this in practice in a way that my child really likes the food and accepts it. But the reduction is not strong enough for severe familial hypercholesterolemia that by itself alone it would have sufficient effects. But it is helpful. It is the basis of treatment. We often say we first do diet alone for 6 months just to teach the family this is something you really need to do as a basis of treatment. However, the response is differently, and we should not only blame the family, but we should also blame the genotype, because not everybody reacts the same way to dietary modification. If you have an ApoE2 genotype, here in the second bullet, then you have a lesser response to dietary modification. If you have an ApoE4 genotype, then you have a very good response to dietary modification, but you wonder whether you really want an E4 genotype, because then you also, at the other hand, have a higher risk of Alzheimer's disease. So nothing is just good or bad, everything is a little bit complicated in biology. So for people with FH, the NICE guidelines have said we really need professional, repeated dietary counseling by an expert dietitian. If we as physicians talk to the family in 5 minutes, it's not enough. It will not be sufficient to really change the diet at home. You need repeated dietary counseling and training. The aim is to reduce saturated fatty acids below 10% of energy intake, cholesterol below 300 milligrams per day, and have an increase of both mono and polyunsaturated fats to above 10% of the energy intake. And that's very different from the normal diet of most populations. So it's a real change in the source of dietary fats. We want to encourage consumption of fruits and vegetables with dietary fiber, and we want to encourage fish intake when possible. There's products that are enriched with phytosterols and phytostanols, and they reduce LDL cholesterol by about 10% or 15%, but they have to be taken on a regular basis to do that. And importantly, of course, we want other risk factors to address as well. We want regular physical activity, we want no smoking, we want normal body weight, and all of this together can reduce LDL cholesterol by at least 10%, often 20%, and even more if families are very much adhering to these recommendations. To do this, it is really important to emphasize information and motivation, because it's a disease where you don't feel anything, you don't have any pain, you don't have any symptoms, so it's very important to understand why this is important. The conversation with the doctor is essential to get families to understand and to motivate them to do that. We often perform dietary protocols, ask the families to write down for 3 days everything the child eats and drinks, and it's very helpful because thereby oftentimes the families themselves realize where the problems lie, and we can immediately identify what the issues are. Repeated counseling and training is important. We measure plasma lipids in the beginning every 3 to 6 months. It doesn't help to measure them every 2 weeks. They don't change that quickly. You can do it at longer intervals. And again, if the lipoprotein levels do not change satisfactorily with diet alone, we add drugs from primary school onwards. We do that if with dietary modification and lifestyle modification, the LDL stays above 190 milligrams or 4.9 millimole, or above 160 and 4.1 in the presence of other risk factors. Early cardiovascular events in the family, high LPA in the child, low HDL, high homocysteine, high blood pressure, diabetes, obesity, smoking. All of these in combination with LDL markedly increase the risk, and therefore then we start drug treatment at a lower level, although we also want to control the other risk factors, of course. What is the options for drug treatment? In the past, we were basing this on anion exchange resins, like cholestyramine, cholestyramine. They work, they're absolutely safe, but they're very inconvenient. It's very difficult to take them for a long period of time. Now, the drug of choice, or first choice, is statin. We have a variety of statins available, and I'll show you the data. The statins have been really well evaluated in children. They are a good option. In children where statins alone do not work, statins, by the way, reduce the synthesis of cholesterol in the liver. The anion ion exchange resins bind the cholesterol and also the bile acids in the gut. And we have a relatively new drug, which is ezetimibe, which also binds cholesterol in the gut and limits the absorption and recirculation. Has the same mechanism as the anion ion exchange resins, but it's much easier to take. And it is used primarily by us in combination with the statins. If the statins alone don't achieve enough effect, then we combine it with ezetimibe. And recently, we have been able to use the PCSK9 inhibitors in children, and they have the benefit that they're extremely effective. They're very powerful in lowering cholesterol. They have the disadvantage that they have to be injected, so that you need a regular injection. So statins, I said, we have very good data. This is a Cochrane review showing that statins lower LDL cholesterol on average by by about 1/3, and importantly, without increasing adverse events. So they're pretty safe and they're effective, and you all know that in adults statins were also shown to reduce the rate of heart attacks, so it's a real good choice to use. However, data show that a number of patients in this study, 30%, have poor adherence with taking the statins that were prescribed by their doctor. Lack of motivation was the most common reason for poor adherence. So again, if you want to be successful in treating hypercholesterolemia, the key is how you talk to the patient and the family. Don't talk to the mother alone, talk to the whole family and talk to the child as well. All of them need to understand if you want to be successful. Ezetimibe, I already mentioned, is a drug that very specifically blocks cholesterol absorption in the intestine. It is linked to the Niemann-Pick C1-like protein 1 that we know from the inborn errors of metabolism. And it is very safe. It has no effect on the absorption of other lipids, which the unknown iron resins can affect. It reduces LDL cholesterol by 15 to 20%, and if you combine it with statin, we can reduce LDL cholesterol by 30 to 60%. And this is our main indication. As I said before, statins alone not sufficiently effective, and then we add ezetimibe. It's very easy, one tablet a day, 10 milligrams a day for everybody, and it's very well tolerated. Side effects are very rare, and it's effective also in phytosterolemia. And then I said in the past we used the resins. They are still good drugs. They are still effective. They have a very good safety profile. The problem is, if you've ever taken them, you know it feels like you put sand in your mouth. So to do that on a regular basis over a long period of time is very challenging. So if we look at the relative effectiveness, statin studies show a wide range depending on the study between 20 and 60% LDL lowering, ezetimibe 15 to 20%, the PCSK9 inhibitors 50 to 70%, they are the most powerful. And again, we can combine them because they have all a different way of working. So let's look at these PCSK9 inhibitors. They are built on a model of a genetic variant where we've seen the children or adults who have a genetic variant in this protease have a markedly different LDL cholesterol. And so then antibodies, monoclonal antibodies were developed that block PCSK9, and that leads to the effect that the LDL receptor is not degraded, but stays on the surface of the cell, of the hepatocyte. The LDL receptor density is increased, and more LDL is extracted from the blood. So a very effective mechanism, but of course, because antibodies, they need to be injected. There's a study in children showing in children very good safety. It has reduced in this study LDL cholesterol by 50% just with the antibody alone. And in Europe and the United States, two inhibitors, two antibodies are now approved for children from the age of 8 and 10 years respectively onwards. So we are able to use them even as registered drugs, not only off-label. They provide really new options because they're so effective, they're considered safe and well tolerated, but we have no data in children on whether they reduce mortality and what the effect is over 10 years, and if there would be inefficacy occurring in some patients because the antibodies could be blocked. So that we need to take into account. So let me conclude. Early diagnosis of severe forms of hypercholesterolemia, like familial hypercholesterolemia, is needed if you want to protect the health of the affected children. We have the options of a targeted diagnostic approach, a cascade screening or population screening, and I can't give you one single answer what to do, but I would say measuring cholesterol one time in a child when you take blood anyway is cheap and easy. Effective and safe treatment options are available based on diet and lifestyle modification and drugs, primarily statins, in combination with ezetimibe and PCSK9 inhibitors where needed. Other novel treatment options are currently being tested, for example, those that reduce LPA. And if we really want to be effective here, I think we need good care in collaboration of a primary care and pediatric lipid specialist, and I should have written down also a dietitian that helps these two to make it work. However, if we find and treat the children with hypercholesterolemia, we will not thereby reduce cardiovascular disease in the population, because if we prevent cardiovascular disease in 1 in 250, the total population rate will not go down. So in addition, we also need to think about promoting population health in all children, healthy diets, regular physical activity, prevent smoking, and all the other factors that you know. Again, I want to advertise the fantastic EAPS Congress, October 17 to 20. If you have an opportunity to travel to Vienna in October, you will like it. It's going to be a fantastic congress in a fantastic city. Thank you very much indeed for your attention.